Hello, everyone. A very good evening, good afternoon to all of you. And I'm Dr. Sunita Patel. I'm a physiotherapist working since many years. 2007, I started working as a physiotherapist, and from 2015, I started working specially into women health. And today, we are very fortunate to have Dr. Akanksha Dixit with us. She has done her master's in physiotherapy in cardiothoracic that particular side of the physio actually. She is certified women health physiotherapist. She has done lot of workshops and learning into antenatal and postnatal exercises. So she is a certified antenatal and postnatal exercise specialist also. She's consultant physiotherapist in Health City Super Specialty Hospital, Lucknow, and she's ex-assistant professor in People's University, Bhopal. We are so glad to have Madam here today with us. And we hope that we will learn new things in this journey where we started learning more about women health. And women health is a very deep subject, deep topic. And this is what is our aim actually. So whatever possible, whatever opportunity we are having, let's learn something. And that's how Dr. Akanksha is with us today. So Dr. Akanksha, over to you. Thank you so much, ma'am, for joining us. Thank you.
Thanks, ma'am. Thank you. Please don't call me ma'am because I have been a student of yours and I will always remain a student of you. And
Today, today I'm
you are
gonna
the
learn from you.
you are the one who has inspired me to move into women's health sector. And thank you so much, ma'am, for providing me this opportunity. And this today's webinar, role of physiotherapy in menopause. This is actually a part of our learning series, which has been initiated by Dr. Sunita Patel, ma'am.
Dr. Akanksha, can we have you on the screen, not the slide? Can we listen from you?
Okay, ma'am. Let me see. Okay.
So, Dr. Akanksha, let me pin. You need to pin yourself, I think. Pin yourself. Akanksha. Pin. Add pin, yes. So now now we can see you.
Okay.
So hi everyone, we have Dr. Akanksha with us.
Good afternoon, everyone. Thank you so much for taking out time on Sunday, the day which we usually try to relax or go out for leisure activities. And here you all are. We are all gathered here to learn more about women's health physiotherapy. So menopause, role of physiotherapy in menopause. This is a topic which all of us know, but not in detail. And this is a part of women's health which has been neglected. So most of us, whenever we talk about women's health, we always think about antenatal, postnatal, but we don't talk about senior citizens or elderly females who have to go through a lot of things during menopause. So please mute yourself. So a woman goes through a lot of things during their whole life because we have so many hormonal changes happening across. Uh, Dr. Jefferson, can you please stop your video? Okay. Sorry. Okay. So let me just start sharing my screen and let me know if it is visible to you all. Is it visible?
Yes, it is visible.
Okay. So my introduction has already been given by ma'am. Thank you so much, ma'am, again. Let's start with this introduction. So menopause, what is menopause? It is cessation of menstrual periods for at least 12 consecutive months, and it is not due to any physiologic, for example, lactation. During lactation, there is hormonal disturbance happening, which can cause the absence of periods or any pathological causes. So it is a normal physiological phenomena. And what happens is, what is the etiology? Complete ovarian follicular depletion occurs such that there are inadequate amounts to respond to the effects of FSH. What is FSH? It is the follicular stimulating hormone. So what is the importance of follicular stimulating hormone? It helps or
Dr. Akanksha,
ma'am.
I'm sorry, I just wanted to know, would you be sharing any material or slides with us later?
Ma'am, you can take screenshot of these slides.
Okay, all right, done. Yeah, thank you.
Yes. Okay. So what happens in menopause is the complete ovarian follicular depletion happens. So what happens is all the ovarian reserves, they are depleted over a period of time because the FSH, which is FSH, is no longer able to stimulate the ovary to release the ovum. And if the ovum is not releasing, so no estrogen will be there. So in turn, there is no luteinizing hormone surge and ovulation does not take place. Okay. So what happens is because of this, over a period of time, estrogen hormone goes down. And because of this, there are various body changes happening in a woman. The affected age range is 45 to 55 with a median age of 51. To make a diagnosis of menopause, the ovarian reserve has been evaluated. So what happens is we have to measure the serum level of AMS, J3-FSH, estradiol, and ovarian anti-follicle count. So all these are medical parts. All the medical part I will be just brushing up and I will go into detail in the role of physiotherapy. So important point is FSH level more than 40 IU per liter is done at least 4 weeks apart is a reliable marker for menopause or impending menopause. There are various stages of menopause. So one is the premenopause or climacteric. So the changes of menopause start occurring 5 to 10 years earlier to the age of menopause. The second stage is perimenopause, then the menopause. This perimenopause stage happens during 5 years earlier to the menopause. And what happens is the periods occur irregular, very irregular. And the menopause happens when there is an absence of periods for at least 1 year. The postmenopause is the stage happening after the menopause is confirmed. So the important difference between premenopause, perimenopause, and menopause would be the difference in the reproductive capacity of women. In the premenopause phase, the reproductive or the fertile capacity is still there. And that is why there are occurrences of late pregnancies in the premenopause and perimenopause. But obviously after menopause, there is no pregnancy. So the types of menopause are also there. One is physiological, which is the normal type, and the another type is pathological. Under pathological type, we can differentiate it into premature, which happens the age is before 45 years of age. And the reason for premature menopause can be oophorectomy, that is the removal of ovaries, certain kind of drugs that block the action of hormones, then hysterectomy, certain types of chemotherapy drugs, they also interfere with the estrogen receptors, then radiotherapy to the pelvic area, again it can be due to radiation therapy for cancer, and certain medications that are used to treat endometriosis or premenstrual syndrome, they can also block the ovaries. And because of this, the estrogen hormone goes down and the premature menopause occurs. The second type is surgical menopause, again due to the removal of uterus or ovary, and delayed menopause. The changes in hormones during menopause, if you can see, the estrogen hormone, first during the premenopause, it goes into lots of fluctuation. During the menopause, there is a steadily decline, and then post-menopause, it is negligible or almost absent. In the stages of early menopause, which we call the climacteric phase or the premenopause, the estrogen hormone is also normal, and FSH hormone is also normal. But during late menopause, that is just 2-3 years before the menopause, the estrogen level also goes down, but the FSH level is increased. Why? Because of the feedback system. The hypothalamus is trying to produce more FSH to boost the supply, to boost the levels of estrogen, but in ovaries there is no ovum. That's why the estrogen is not happening. Okay. Then the effects of menopause on different body parts. So all the body parts are being affected. Central nervous system, skin or mucosal or hair changes, sexual function, urogenital system, weight and metabolic changes, and musculoskeletal system. So what happens is gradual atrophy of all the key target organs of estrogen occurs. So where are these key target organs of estrogen? The first part is vagina. What happens to vagina physically or anatomically? It becomes smaller, thinner. It has decreased vascularity and gradual loss of rugae. What are rugae? All of you know rugae. In the vaginal wall, there are structures which is rugae, and this rugae, because of this rugae, there is elasticity of vagina. Then endometrium. This endometrium becomes gradually thin and atrophy occurs. Uterus also becomes smaller in size, and if the fibroids were present earlier, then they also start to atrophy. There is no need of surgical removal of fibroids until unless it is very symptomatic. So then the pelvic ligaments, they also become weaker, predisposing to pelvic organ prolapse, and pelvic floor muscles become weaker and less elastic, and bone demineralization occurs. The symptoms of menopause. There are a lot of symptoms of menopause, ranging from vasomotor symptoms to musculoskeletal systems. Patient also has complaints of fluctuating mood. They have a lot of anxiety, depression, irritability because of decreased strength of pelvic floor muscles. There is also incontinence. Then there is increased risk of coronary artery disease because the estrogen hormone, it also has a protective feature for our woman body. It helps in decreasing the fat absorption. But because of decreased estrogen, there is increased fat absorption in the body, increased fat accumulation in the body, and it causes increased risk of coronary artery disease because it may cause atherosclerosis. Then there is a particular symptom of menopause which is called as hot flashes. Many of you must be familiar with this. This hot flashes are due to vasomotor symptoms. There is headaches and migraines, difficulty in concentrating, brain fog also happens. There is loss of libido. Then the postmenopausal health ailments found in Indian women are most commonly hypertension, coronary heart disease risk, cancer, obesity and allied health issues, osteoarthritis, urogenital problems, sexual problems, and the psychological changes. Under these headings, we can differentiate them. The genitourinary syndrome of menopause, this term has been defined recently in 2015. So it is a more accurate and inclusive term that describes the multiple changes occurring in the external genitalia, pelvic floor tissues, bladder and urethra, and the sexual sequelae of loss of sexual function and libido. And all of this is caused by hypoestrogenism. Okay. So what happens is, because of all the anatomical changes occurring in the pelvic floor and the pelvic ligaments, there are the symptoms which are happening is urinary incontinence. Let me go back. Urinary incontinence, and also there is dyspareunia. Because of decreased elasticity of vagina, what happens is this female also feels vaginal dryness, and because of this, dyspareunia also happens, which is the pain happening after or during the intercourse. The bone demineralization also associated with menopause, it manifests itself years later. And because of this, there is decreased height of the female, not much more, but yes, in centimeters, in few centimeters, increased curvature of spine, kyphosis, and silent fractures of vertebrae happening with compression on mild trauma. There is a scale used to used to describe the severity of menopausal symptoms which are experienced by the woman, and it is called as one of it is called as menopause rating scale. So it consists of a list of 11 items, and each of the 11 items can be given a number between 0 to 4. So the total score is between 0 to 44 since there are 11 items, and because between if the score is less than 11, then it is called as asymptomatic. If it is between 12 to 35, then it is described as mild to moderate symptomatic. And if it is more than 36, then severe or very severe, it can be classified. And it needs medical management also. The menopause rating scale is this. We have hot flashes, heart discomfort. Heart discomfort can be described as palpitations or a lot of dysrhythmias, a tightness feeling in chest, then sleep problems. There may be insomnia that they are feeling, depressive mood, anxiety, irritability, then physical and mental exhaustion. Fatigue is very common in menopausal women. Sexual problems, changes in sexual desire, then bladder problems. It can be due to difficulty in urinating or urine leakage with stress, then dryness of vagina, and joint and muscular discomfort. So all of these symptoms have been categorized into these 11 points, and a woman will explain her score in between 0 to 4, categorizing as none, mild, moderate, severe, or extremely severe. Are you all following me?
Yes, we are.
Yes.
Yes, ma'am.
Okay. The medical management of menopause. So we'll just brush it up all the medical aspects, and then we'll focus later into role of physiotherapy. The medical management of menopause may the hormonal therapy for hormonal replacement therapy. Vasomotor symptoms are the main indications. So apart from this, hormonal therapy can also treat other menopausal symptoms such as sleep disorder, depression, and musculoskeletal pain, and may enhance the overall quality of life of women. Okay. For vaginal discomfort or the vaginal dryness and dyspareunia, vaginal lubricants and vaginal moisturizers can be offered, and local estrogen therapy is also given. It is usually the first line of treatment because systemic estrogen is given very less because of the risk of carcinomas. So the systemic therapy, it is indicative only during severe, very severe cases and not in mild to moderate. So these are few of the estrogen, progesterone, and the combination of estrogen, progesterone, tribolone, and estrogen therapy drugs used for genitourinary syndrome and vasomotor syndrome. Okay, you can take a screenshot of this. People who, some of the undergraduates are also here. If they
Dr.
want
Akanksha.
screenshot.
Dr. Akanksha,
Yes,
can I
ma'am.
just? Yeah. I just wanted to know what do you mean by extremely severe cases? What do we see in there?
Extremely severe cases, we differentiate on the basis of MRS, the menopausal rating scale, which we have just discussed. On the score of more than 35 to 44 score on MRS is termed as extremely severe case of menopause. Symptoms, in case of symptoms, I mean. Okay.
Yeah, thanks.
Okay. Shall I continue?
Yes, please.
Okay. So next we come to role of physiotherapy in menopause, which is our main topic. So what, as a physiotherapist, what is our duty? So we have to educate patients about the symptoms and progression of the condition. Because usually when a woman around 40 years of age, 40 to 45, start experiencing these symptoms, we do not immediately think about menopause. First you are in denial stage. Oh, I am so young. So you start having few little symptoms regularly about joint pain, then irregular periods, back pain, and then some amount of dyspareunia. So if the patient is regularly coming to you on physiotherapy regarding other joint problems, you can also ask about their period history, okay, their gynecological history or their obstetric history. If you ask them about their gynecological history, then you may know, and you can also explain them or educate them about the symptoms and the progression of menopause, what all symptoms are expected, so that the female is more aware and mentally prepared about. So the first part was patient education, then the postural advice. If you notice that there is kyphosis present in the female, then you have to advise on the posture, because the kyphosis is going to cause more problem in cervical spine, thoracic, as well as lumbar spine also. Then lifestyle modification advice, which we'll take on later. Advice on bone, joints, and muscle health and importance of regular exercises. Then you can assess for pelvic organ prolapse and incontinence and design a progressive pelvic floor rehabilitation program, and devise an individualized exercise plan to combat both menopausal weight gain, cardiovascular symptoms, osteoporosis, and frequent falls. Then the electrical modalities for muscle stimulation and pain relief. So even though we are talking about menopause, but all of you must have realized right now that we don't have to go in women's physiotherapy only. We have to incorporate cardiac rehab also. We have to incorporate orthopedic rehab also, and we have to do pain management also. Okay, so it is an umbrella. This menopause rehabilitation does not it is not located to only pelvic floor muscle training. It has to be done in this whole umbrella. Then the incontinence associated with menopause. The common causes of a menopause. We'll take all the symptoms one by one, or the conditions one by one. The common causes of a menopausal sensitive bladder is weak pelvic floor muscles. Why? Because earlier we learned that there are anatomical changes happening in pelvic floor muscle also. Sarcopenia happens, which is a generalized phenomena. All the musculoskeletal system goes under these changes, atrophical changes. Then prolapse, less bladder elasticity, the depletion of estrogen, and weight gain. Because of decreased estrogen, there is more fat accumulation and weight gain, and it can also cause pressure over the bladder. The types of urinary incontinence which happens in menopausal. Hello. Types of urinary incontinence happening is stress, urgency, overflow, and make type. What is stress urinary incontinence? It happens when the urine leaks out at times when the bladder is under pressure. That is during coughing, sneezing, laughing, or while lifting any weight, the urine leak is happening. Then the urgency type of urinary incontinence is when the urine leaks on feeling a sudden intense urge to pee, or soon after the lady or the person start having urge to pee. Then why does it happen? It occurs due to contraction of detrusor muscle at the bladder filling stage. The stress urinary incontinence happens mainly due to pelvic floor muscle weakness because of the loss of sphincteric action, and urgency is more common with the hyperactivity of detrusor muscle. Okay, so both are different in their etiology, but the symptom is same, urinary incontinence. One happens due to sudden pressure or load on the bladder, and the another one happens whenever there is a urgency or urge to pee. Then the overflow type of urinary incontinence is involuntary leakage of urine from an over-distended bladder, which happens due to impaired detrusor contractility. So in urgency type, what was there? Detrusor hyperactivity or hypertonicity was there. But in overflow type of urinary incontinence, there is detrusor hypoactivity. Okay, then there is a mixed type of urinary incontinence. So during menopause, what we see more is of stress urinary incontinence, urgency incontinence, and the mixed type. During urinary incontinence, how we can measure the urine leakage, or how we can know that there is a what is the severity of urine leakage. We can use a simple pad test, which involves the patient wearing a pre-weight pad, and after wearing a pre-weight pad, the patient drinks 500 ml of sodium-free liquid in less than 15 minutes, and then rest, after which he or she exercises for 30 minutes. In our case, he exercises for 30 minutes. The exercise would include activities such as walking, climbing up and down a flight of stairs, then standing up from sitting, coughing vigorously, and running on the spot for 1 minute. So what all these exercises do, they put a stress on bladder, and then the pad is then reweighed, and the resulting measurement is given in grams of urine loss. Okay, by which we can confirm the urine leakage of the urinary incontinence of the patient. And whenever we do this pad test sequentially after certain amount of time or periodically, then we can measure, or we can take this as an outcome measure to know how our rehab is helping the patient. Okay. Now, the management of urinary incontinence. The very first line of treatment for urinary incontinence is pelvic floor muscle training. So pelvic floor muscle training can be given by the exercises, and the exercises can be done freely or with the help of vaginal cones. During the earlier stages of rehabilitation, only 3 exercises are being asked for the patient, because the pelvic muscles are very weak in these patients. So first we have to teach them, make them aware about the pelvic floor. And we have to tell them where exactly is their pelvic floor located, how to feel it, how to know that you are contracting your muscles correctly. Because what happens is, usually patients think that they are contracting the pelvic floor, but what they do is they just tuck their tummy in, or they just squeeze their buttocks. So very first thing important to consider is, we have to make the patient aware of pelvic floor muscles. Okay. So first we have to only ask them to do activation, and later in the resistance training, we can use these vaginal cones. These vaginal cones are weighted vaginal cones, which can be inserted inside the vagina, and then the patient will be asked to do the pelvic floor exercises. So these vaginal cones will also provide feedback to the patient how good they are contracting. The behavioral therapies are also used, which I'll take in the next slide. Electrical and magnetic stimulation and mechanical devices which are used, pessary. This is a pessary which can be inserted. This will be helpful in the case of urinary bladder which is associated with prolapse. Okay. These are the few of the devices which can be used. The pelvic floor muscle training or the rehab. So we have to educate the patient, which I have already told. We have to improve the tone and strength of the muscle fibers. Desensitization of the painful areas can be done by using deep friction massage. On palpation, when we find that there are few trigger points present, then we can do deep friction massage to release it and improve the flexibility of the tight pelvic areas. For this, we can release iliopsoas muscle also and piriformis muscle. This will also help in improving the pelvic floor function. So this is just a combination of the summary of whatever we are going to do. Enhanced pelvic floor muscle strength will help in increase in levator and eye muscle strengthening and reflex activation. There is maximized awareness of timing, which helps in the urethral sphincteric action, improving this. Then strengthened core muscles. All of these will help in urethral hypertrophy, and the urinary incontinence will improve. To assess the pelvic floor muscle, we can use this modified Oxford grading system, but this is a penetrative exam. So one has to insert one digit and then ask the patient to contract. So before this, you have to make aware the patient about pelvic floor muscles and the action. So this is the grading system. 0 is no contraction and no lift. So what we are looking in this modified Oxford grading system, we are looking both for the squeeze as well as the lift of the pelvic floor muscles. So this squeeze and lift is where we are feeling around our digit. The grade 1 is flicker squeeze, there is no lift. Grade 2 is weak squeeze, there is no lift. And grade 3 is moderate squeeze with lift. If you can see this video, is this video visible to you?
Yes, ma'am.
Okay. Then grade 4 is good squeeze with lift, and grade 5 is strong squeeze with lift. Okay. Shall I move ahead? Everyone has seen this video?
Yes.
Yes, ma'am. Yes, ma'am.
The other type of scale which we use to assess pelvic floor muscle is perfect scale of grading. So how does it define? P is for power, and the power we measure by modified Oxford grading. E is the endurance. It is the time in seconds that a maximum contraction can be sustained. Then R is the repetition, the number of repetitions of a maximum voluntary contraction. S is the fast contractions occurring in 1 minute, and every contraction time. Okay. So these two scales are mainly used to assess pelvic floor muscle grade, which we can periodically assess to know about the improvement of patient's symptoms or the patient's muscle strength as an outcome measure. The behavioral therapy which we can use for incontinence is bladder training. We have to start by asking the patient to trying to hold up for at least 10 minutes every time you feel an urge to urinate. And the goal is to lengthen the time between trips to the toilet until the urination occurs only every 2.5 to 3.5 hours. Okay. So this bladder training is useful in which type of urinary incontinence? Urge incontinence. The double voiding. What is double voiding? When the patient goes, this double voiding is useful for overflow type of urinary incontinence. The patient is asked to go to urinate, and then she's asked to sit there for a few seconds, wait for a few seconds, 10 to 15 seconds, and then again try to urinate. So this will help in complete voiding of urine from the bladder. Please mute yourself. Then the scheduled toilet trip and fluid and diet management. The patient is usually asked to have low sodium diet. The techniques used in pelvic floor muscle training or pelvic floor rehab is Kegels exercises. So what are the commands given to the patient? The patient is asked to squeeze and draw in the muscles around your anus and vagina and urethra also. This is not being written, but the patient is asked to contract all the 3 parts of pelvic floor muscles around all the 3 openings to squeeze in a sequence from front, back, front, medium, and for anterior. Lift them up inside and feel a sense of relief lift each time you squeeze your pelvic floor muscles. You have to first squeeze and relax, squeeze and relax. And once the patient is proficient in doing this, then we ask them to squeeze and hold for a count of 5 to 8 seconds. And then the patient is asked to relax. Between each repetition, we have to give relaxation time also almost equal to the amount which we have asked to hold them. 5 to 8 seconds of hold followed by 5 to 8 seconds of relax time. The patient should also be able to relax completely. This is also important. And these Kegels progression, how we can progress these Kegels. You should not just tell them or ask them to just keep squeezing, relax, keep squeezing and relax, and then you just have to hold. How we can progress these exercises? First, initially we are only asking them to activate, So the initial position of the patient during initial phases of rehab will be while sitting on a chair. So when you are sitting on a chair, I am just a sec. I want all of you to practice this with me. Okay. Okay. All of you, please try to sit on a chair and try to move forward. Let's have a quick pelvic floor muscle contraction here.
Akanksha, can
Are
you
you all ready?
come into the screen? Just stop this one and you please come on the screen.
Okay.
Thank you, dear.
Okay. Is it okay? All of you, please switch on your cameras. So I want all of you to come forward on your chair. Are you all sitting on a chair, high chair?
Yes.
Yes, ma'am.
Okay. So try to come sit on the edge of the chair, and I want you to abduct your knees. Keep your knees apart and try to just bend forward. When you bend forward, are you able to appreciate that your pelvic area, your perineum area is just touching the edge of the surface of your seat? Are you all doing? You
Yes,
have to
ma'am.
come forward on your chair. You have to on the
Yes, we are able to.
okay. And then now you have to keep both your hands on the knees. You have to lift your heels so that your leg is externally rotated and abducted, hip. And now just try to bend forward. When you are come in this position, your whole of the perineum is in contact with the seat of your chair. So now if I ask you to squeeze the pelvic floor, are you able to appreciate the lift of perineum from the seat of chair? Are you all doing?
Yes, ma'am.
Yes? Okay.
Yes.
Yes, ma'am.
So in this way also, we can ask the patient or we can educate the patient about how they are isolating their pelvic floor. Okay, everyone is clear with this? How we are teaching the patient to isolate these muscles? Once we make them understand how they should contract their pelvic floor correctly, then it's very easy to just change the position of patient every time to increase the difficulty level of exercise. Okay. Let me come back to this. Okay. So initially, what we have done, we have told the patient how they can isolate these pelvic floor muscles while sitting on a chair. And then we can later ask the patient to hold the contractions in the same position. For 3-5 days, we'll be continuing these exercises while sitting only. And we can also ask the patient to do home exercise program of doing these exercises twice a day, and at least 5 to 8 repetitions will be done per set. So later, we are asking them to hold the contractions. And after this, we have to aim to do at least 6 to 12 squeezes each set, and 3 sets of 8 to 12 squeezes are done with a rest period of 1 minute in between each set. This 1 minute is not written there, but please, if you all are writing or taking notes, then please write this. A rest period of 1 minute is also given between each set of 8 to 10 contractions. So then how we can increase the difficulty level? We can ask the patient to come in supine lying. In supine lying, if they do, the body awareness is also happening more in there. Then the pelvic floor muscle contractions can be coupled with leg movement. How we can do? We can ask the patient to do straight leg raising along with contraction of pelvic floor muscle. We can ask the patient to bend both the legs and then perform bridging and do pelvic floor muscle contraction. And then we can ask the patient to do pelvic floor muscle contraction along with the functional movements. These functional movements can be what the pelvic floor contractions along with the change of posture from sitting to standing, or while walking, while marching at the one spot, sorry. And then these exercises can also be coupled with TA activation, transversus abdominis. So how they can do? Again, same position, supine line. We have asked the patient to come in crook line position, bend both the knees together. And then while contracting the pelvic floor muscles, we can also ask the patient to do abdominal contractions to tuck their tummy in. So both of these exercises will improve the recovery of pelvic floor muscles also. Then the fast twitch contractions. Initially, what we have asked is slow contractions, slow sustained contractions with hold. The second type of exercise is also important, which are fast twitch contractions. The maximum amount of contractions that they can do in 30 seconds or 1 minute. Okay, accordingly, the stages of rehab, we can ask them to do in 30 seconds or for 1 minute. So the fast twitch contractions, it is helpful for improving the strength or power of the muscles. For endurance, we have to teach about them slow sustained contractions. The abdominal bracing is same. We have to work on core activation muscles. Then neck maneuver. This neck maneuver is being taught to them it is similar to how we are squeezing the pelvic floor, but it is just a protective technique for them to prevent this urinary incontinence. Whenever the patient, even this neck maneuver also patients usually do subconsciously. Whenever they are having any coughing or they are lifting any weight, they just hold their breath and they contract the pelvic floor muscles to improve the sphincteric action. Okay. So what is the difference between neck and Kegel exercise? It is just a selectively timed event. And Kegel exercises, we are doing it as a strengthening protocol, the repetitive contractions. This neck maneuver, this is done only once. The patient only does it whenever she feels like the urine is about to leave. Okay. So we are only focusing on Kegel exercise. This neck maneuver, mostly patients, they do subconsciously. And the lumbopelvic stabilization exercises are all the exercises which are helping here. The gluteal maximus strengthening, the hip abductor strengthening, piriformis strengthening, then the core activation and the lumbar stabilizer muscles, the strengthening of erector spinae as well, hip adductor stretching. So we have to just not focus only on the pelvic floor muscles, but we have to incorporate all the lumbar pelvic muscles. Okay, this will also help in improving our urinary incontinence symptoms. Now we come to electrical stimulation. So mostly exercises part are sufficient for stress urinary incontinence. But if the patient is having a lot of symptoms, a lot of urine leakage problem, then we can also incorporate electrical stimulation in this. The indications for electrical stimulation would be the stress urinary incontinence with sphincter weakness, then impaired pelvic floor balance, overactive bladder, and I have not written here urge incontinence, but urge urinary incontinence is also an indication for electrical stimulation. And there is a separate type of stimulation parameters there for urge urinary incontinence. Then recurrent pelvic surgery failures. The contraindication where we will not be giving electrical stimulation would be the active infections of genitourinary tract, any pacemaker conductors, or any hemorrhagic diseases. We will not be giving electrical stimulation there. So for urge urinary incontinence, this transcutaneous tibial nerve stimulation is a very commonly used non-invasive stimulation. The posterior tibial nerve is a mixed nerve and it also contributes to bladder control. So the bladder innervation and posterior tibial nerve innervations, nerve roots are same, F2, F3, F4. So these, what is being hypothesized is when we provide stimulation to tibial nerve, Then the afferent nerves of afferent part of tibial nerve, it causes inhibition of hyperactivity of detrusor muscle. So this stimulation of transcutaneous tibial nerve, what it causes, it inhibits the detrusor muscle activity. And because of this, the reflex contractions are inhibited and there is improve in the urge urinary incontinence symptoms. The first tense uses transcutaneous tibial nerve stimulation, and the another type is uses parasacral transcutaneous electrical stimulation. This is also a non-invasive type of stimulation, and it uses a low frequency current in S3 region with the aim of promoting an inhibition reflex for detrusor muscle. Let me show you the electrode placement for these. For tibial nerve group, it is the posterior tibial nerve. To stimulate, we have to keep it around the medial malleolus and just the lower part of calf. And for the parasacral group, we will be keeping the electrodes in sacral area. Okay. And the parameters which are used is the current level of 0.5 to 9 milliamperes at 20 hertz is given with a pulse width of 200 microseconds. And each session lasts for 30 minutes. The previous one was for urge urinary incontinence, and now this electrical stimulation parameters are for stress urinary incontinence. For stress urinary incontinence, this kind of vaginal plug is used. This vaginal plug is inserted into the vaginal part, and the parameters which are used are current biphasic rectangular pulses are given in the range of 30 to 80 milliamperes. Again, it depends, the intensity depends upon the patient tolerance. If the patient is sensitive, then even 30 milliamperes would be more than sufficient. The duration would be 0.2 to 1 millisecond, and duty cycle uses 1:2 ratio. There are 30-minute sessions done 3 times per week for 12 times. So these parameters, this 30-minute sessions 3 times per week is for the previous electrical stimulation part also for the urge urinary incontinence. And the frequency here used is 20 to 50 hertz. Then comes the interferential therapy. The interferential therapy, the patient position is semi-Fowler's position. As you can see, quadripolar method is used. Two electrodes are placed just above the inguinal ligament, around the inguinal ligament, and the another two are placed around the ischial tuberosity, just near to the origin of adductor muscle, and adductor muscles they originate from IT. So intensity again up to the tolerable limit is given, and the frequency is given 2000 hertz carrier frequency, and rhythmic sweep frequency of 10 to 100 hertz is given. The duration given is 20 minutes. You can take screenshot of this slide. So whenever we do interferential therapy or whenever we provide electrical stimulation of pelvic floor muscles, we always ask the patient to also contract or squeeze when the current is passing. During the on period of current, we also ask the patient to do active contractions so that the results are better as compared to only electrical stimulation or only pelvic floor muscle exercises. So the combined effect is always better. Then the perineometer can also be used. It is a type of biofeedback also. So this sensor is inserted inside the vagina and it is connected to a pressure area which has the adjustable resistance. And whenever the patient squeezes, we can have a display of the pressure generators. So these pressure generated over a period periodically can also provide our evidence that how much muscle function is improving. The biofeedback, same funda. The patient is able to gauge how much they are producing, how much effort they are producing with their pelvic floor muscles. Then we move on to the another condition associated with menopause, the kyphosis or posture correction. So the kyphosis or posture
Dr.
correction.
Akanksha, I'm sorry, just give us that EMG slide, no?
Okay, ma'am. There's not much into this. Do you want to take a screenshot?
The placement of the electrodes here
Yes, ma'am.
will differ, right? If we have to go in for the placement of electrodes for the EMG.
This is insertable, ma'am. Vaginal insole.
Yeah. Okay, all right, yeah, thanks.
Okay. Now the kyphosis. So to improve the kyphosis, we have to provide thoracic mobility exercises and spinal extension exercises, which we are all practicing in our regular practice, and the breathing exercises to improve the lung function. The extension exercises, scapular retractions, thoracic extensions, and hip extensions. All of these are the exercises, the regular exercises which we are providing to for our low back pain and our dorsal ache patients also. So flexion exercises are contraindicated in these patients because osteoporosis is also associated with menopause. And because of this osteoporosis, whenever we provide flexion, extreme flexion, by flexion I mean extreme flexion exercises, then they can cause vertebral compression fractures. So flexion exercises are contraindicated in postmenopausal women, depending upon their osteoporosis. So these are few of the safe exercises which we can ask our patient to do back if they are very elderly. Back extension exercise in sitting position, and the pectoral stretching exercise. If you increase the flexibility of pectoral muscle, then obviously the posture will also improve. Then comes the osteoporosis part. So it is defined as low bone mineral density, which is caused by altered bone microstructure and ultimately predisposing the patient to low impact fragility fractures. So most menopausal women, they commonly lose 1% per year after peak bone density has been met. And this demineralization or these osteoporosis process, this can continue up to 8 years after menopause. Okay, so depending upon the BMD, the normal bone mineral density, it can be, there is the whole grading system. If the score is between less than minus 1.0, it is osteopenia, and if it is decreased less than minus 0.25, it is osteoporosis. So the patients with diagnosis of osteoporosis should also have a laboratory assessment of their renal and thyroid function, their vitamin D and calcium levels, and this DEXA scan is the one which gives a proper diagnosis of osteoporosis. We already know most of these things. The clinical signs and symptoms are back pain. Back pain be due to decreased height of the spine, and it can be due to kyphosis also, and it can be due to osteoporosis per se. Then the compression fracture of the spine, these are usually the silent fractures. Bone fractures happening over mild or trivial trauma. The decrease in height, kyphosis, Dowager's thumb, which we usually see in the dorsal spine, becomes a slightly lumped, the extreme case of kyphosis, and decreased activity tolerance. The medical management, these are few of the drugs which are being used. If anyone wants to take screenshot, then please take. I will not go into the detail of these. Then the nutritional management. These are the guidelines which are used for nutritional management. Mostly calcium, vitamin D, and protein-rich diet is being given. Please take the screenshot. The iron-rich food is also given. Foods which are rich in phytoestrogen, that is the plant-based estrogen, they also help in increasing or improving the rest of the symptoms, which are hot flashes and irritability, anxiety, apart from helping in osteoporosis, obviously. So this is a very beautiful photograph picture for these superfoods of strong bones. Vitamin D supplements, and then the physical activities. For physical activities, the exercises which we are prescribing them, it depends upon the how we prescribe our rehabilitation on fit principle. So intensity would be, frequency would be 2 to 3 times per week. Then in comes the intensity. Intensity is given moderate intensity physical activity. This intensity factor can be gauged or can be controlled to their heart rate, resting heart rate, and their RPE, rate of perceived exertion. I will describe in another slide. And the activity types of the exercise would be walking, jogging, swimming, or cycling. Basically, low impact exercises are prescribed, and time is the almost 45 to 50 minutes of exercise. Now, the type of exercises which we are using are weight-bearing aerobic exercises. Weight-bearing aerobic exercises, low impact exercises, moderate impact exercises. In this, or either the arms, feet, or legs or are bearing the weight. So examples would be walking, stair climbing, jogging. These are the volleyball, tennis, or any other sports are the moderate or high intensity, which can be given in relatively younger women and or those who are already active. Then the principles of impact exercises is about 50 impacts on most days of the week are asked. The flexibility exercises are 10 minutes after every workout, we can ask them to do. In fact, the warm-up part and cool down part of our rehab would be incorporating flexibility exercises. So we have to provide flexibility exercises to all the major muscle groups of body, and we should ask them to hold each stretch for at least 30 seconds. And if they are unable to do 30 seconds, then at least start with 10 seconds and then later they can increase it. We don't have to provide more repetition. We have to just increase the hold. The another type of exercise which we have to ask them to do is balance exercises. So these balance exercises are done 15 to 20 minutes per day and 3 days a week. Yoga and Tai Chi can also be done. Most of the balance exercises which we can ask them to do is standing with feet closer together, then standing on one foot or standing with one foot in front of the other, the tandem walking. Then we can ask them to do first while opening their eyes, and later we can ask them to close their eyes also and then perform the exercises. The strength or resistance exercises, in which the joints are moved through against some type of resistance in the forms of any free weights, therabands, or the body weight exercises. Some examples of exercises which we can ask them to do for upper body and spine will be wall press up, bicep curls, tricep press. So these are all the exercises which we are already providing in our orthopedic rehabilitation in our daily day-to-day practice. The examples of exercise which are for lower body, which is very commonly used for these menopausal, post-menopausal women, and which are also very safe, is mini squats or wall supported squats, sit to stand, then hip flexion abduction, which is the supine SLR and sideline SLR, beam raises, bridging. So these are very safe and can be done in all the osteoporotic women, in most menopausal women. So these are the few of the low impact weight bearing exercises which we can ask them to do: sit to stand, squat, half squat, low impact aerobics, walking, toe raises, and the high impact weight bearing exercises which are running, tennis, skipping. These we will prescribe only to those who have already been active since years. We will not ask a new patient to start doing these new exercises. Always go for first low impact weight bearing exercises. And if the osteoporosis is severe, this is a summary of all the exercise protocol of these weight bearing or impact exercises. Please take a screenshot of this. This summarizes it beautifully. And if you have any doubt, then you can please ask me. But please take a screenshot of this. Whatever I have just explained, this is a summary of this only. Okay, let's move on. Now, the electrotherapeutic obesity management. I'm not sure about how much evidence is there, because there has been very few studies done on these. But yes, there are few studies done on rabbits that extracorporeal shockwave therapy, it accelerates bone formation, and low-level laser therapy can also activate osteoblasts. So very low evidence on this, but yes, these two studies have been done recently in last five to 8 years. And no, this has not been done regularly, but yes, since it was available, the literature, so I have just incorporated in this slide. Then comes the arthralgias and myalgias. So all the arthralgias and myalgias will be due to loss of muscle mass, which is called as sarcopenia, and it happens in pelvic floor also, and for the other system, all the other muscle, skeletal system also. So these muscle mass is lost at a rate of 1 to 2% a year in postmenopausal women, and the bone loss is there. How much bone loss is there? 1% per year, up to 8 years after menopause. And this muscle mass is also lost at a rate of 1 to 2% a year in postmenopausal. But what we can do is we can provide them a progressive exercise protocol which can help in decelerating this loss, or even stop this muscle loss. The weight bearing exercises is most important because it helps in improving bone density, which we have done earlier also. And now comes the pain management. The pain, we can ask the patient, all the arthralgias or myalgias, they can rate their pain on the basis of NPRS, numerical pain scale, pain rating scale, which we are all aware of, from a scale of 0 to 10. The electrotherapy which we can do for these pain relief is cold compressions, hot fomentations, ultrasound over the tender points, interferential therapy, TENS, laser, shockwave therapy. The usual pain management which we are doing in our orthopedic rehabilitation practice. If anyone asks me doubts regarding this, then please ask. But I don't think I need to explain more on this.
Ma'am, what is shockwave therapy?
Shockwave therapy is a modality which use intermittent shock waves is given to the patient. Like we are giving IFT TENS. It is also an electrotherapy modality, shockwave therapy. I think you can please read it online. I cannot explain you the whole modality here, but yes, you can Google it, and then you can ask me again if you still have doubts, Nikita. Okay.
Okay, ma'am.
Since you are just an undergraduate, that's why maybe you're asking. Then comes the vasomotor symptom management. Now, the vasomotor symptoms, the hot flashes or anxiety, these can be managed by certain yoga poses, and also the slow deep breathing exercises. So what slow deep breathing exercises do is it works on the parasympathetic system. The vagal stimulation happens whenever we do slow deep breathing. The vagal stimulation happens, and it will help in regulating the vasomotor symptoms, because it is the parasympathetic system, nervous system will be activated whenever we do slow deep breathing exercises. And these certain yoga postures are also helpful. The downward facing dog and the legs up the wall. Okay, the knee to chest, double knee to chest. The most common exercise which is helpful is in our practices, slow deep breathing exercise. Then the menopausal obesity. The menopause has been identified as a high risk stage for weight gain in a woman's life cycle, and it is a consequence of because of decreased estrogen levels. So it is also been observed that the severity of menopausal symptoms is higher in obese women as compared to non-obese women. Also, this obesity will cause comorbidities, and so we have to focus on weight loss program of these menopausal obese women. So dietary management is also being given, then medical management is also given, and later, and obviously physiotherapy management is also there. The dietary management is based on introduction of calorie deficit diet while improving the overall quality of diet, and the calorie deficit is achieved by reducing 500 to 750 kilocalories from the current calorie intake. For initiating a weight management intervention, the classes of obesity should also be identified according to the BMI of the patient. So for 23 to 24.9 kg BMI, the patient is overweight, and we have to only simple weight loss exercises program and nutritional advice can be helpful. But if it is more than 25 and the obesity is diagnosed, then apart from nutritional and exercise program, even surgical and medical management is also advised. The cutoff reference for initiating weight management should be, or the outcome measure should be, waist circumference less than or equal to 72 centimeters is considered normal. But if the waist circumference for more than 72 centimeters, but it is less than 80 centimeters, then we have to initiate weight management advice. But if it is more than 80 centimeters, then it is termed as severe obesity, and it is associated with cardiometabolic comorbidities, more cardiometabolic comorbidities, and in intensive weight loss management should be initiated. So this weight loss should also be slow and gradual. Immediately, we cannot ask the patient to lose a lot of weight, and they will also not be able to lose a lot of weight. A stepwise body weight loss goal would be set with a target weight loss of 0.5 kg per week, attaining a weight loss of 5 to 10% of baseline body weight for 6 months. And this is called as clinically significant weight loss. So preferably, again, how we will prescribe the rehabilitation for this, again, depend upon FIT principle. So the daily 60 minutes of physical activities should be recommended, including a combination of moderate intensity aerobic exercises, which will be done, and muscle strengthening, major group muscles, engaging major muscle groups or balance exercises, and work-related and or household-related moderate physical activities. So this, apart from these 60 minutes, there will be 30 minutes of aerobic exercises, 15 minutes of resistance training, and 15 minutes will be moderate level physical activities which the woman is already doing at her home, or our household related activities. The women can participate in moderate intensity aerobic activities in short bouts throughout the day also. If they are unable to give 30 minutes of their time at a stretch, then we can also ask them to do short bouts of exercises, high intensity interval training throughout the day, 2 to 3 times a day. So the intensity of these exercises would be depending upon the RPE. RPE is the, what is RPE? The rate of perceived exertion. On this scale, we will ask the patient to monitor their own exertion level between, and the intensity which we have asked them to do is 3, which is moderate level of exertion while doing the exercise. And the talk test can also be told to the patient while they are doing it. Is what I have understood is when I ask my patients to scale their exertion level on RPE, then it becomes difficult to all of them to understand. But the talk test is very easy for them to understand. That whenever they are doing the exercises, if they are able to talk, because usually what all we do, we also, whenever we are on a phone call, we always just walk and talk, you know. So most of the females, they relate to this talk test, or even the other patients also, male patients also, they relate or they understand this talk test very easily. So what I ask them, whenever I give them home exercise program, then I ask them to keep to understand how much level of intensity they have to do. So if they, while doing exercises, they are able to talk comfortably, then it means that their exercise intensity is light intensity, or is it okay. But if they are talking if they are talking but feeling a little breathless, but still they are able to talk and also perform exercise correctly with less amount of difficulty, then it is moderate intensity. But if they are unable to talk, they are having a lot of breathlessness, they are panting for breath, then that means that they have increased their intensity level, which should not happen. They should only do moderate intensity. So they should be easily able to talk while doing the exercises. And all the exercises which are given are safe for low impact exercises will be chosen, because they also have, because of obesity, they also have associated obesity. Just me 1 minute. Okay, sorry. The next symptom which we are having is postmenopausal depression. Again, all of us know that our regular exercises, what they do is, regular exercises, they increase serotonin hormones, and these serotonin hormones help in improving the depressive symptoms or the anxiety symptoms. So these depression post-menopause is mostly due to the less of estrogen levels and less serotonin levels. So whenever we ask them to do regular exercises, which we are already giving them for obesity and for osteoporosis, so this will also help in improving their depression symptoms. So these are few of the references which I have done, and thank you. We are now open for question answer session.
There was this one image for downward dog pose and the leg up. Okay.
Yes.